11:30, we are going to start. It's a real pleasure to be the chair of this session. We prepare with very enthusiasm because we are going to be among friends, and this is very important. I'm sure we are going to improve so much and learn so much. When you have the responsibility to prepare a patient to go to the surgical theater, you must take care about many aspects. That's the reason we are all here today. Aspects like preparation, anesthesia, if you have to prioritize, independent the related disease or the associated disease the patient have, or maybe how you do the discharge, the same day, maybe later, fast track, it depends. So Eddie is going to explain, Eric Stenberg, how to vote.
So welcome. Yeah, this is an interactive session. So each of you who has downloaded the app, I hope all have done that, can go into this session. You can click on the session, you can click on interactive features, and there you will find something called poll, and you can vote after both pros and cons has been presented. Then you can vote on whatever you think. Is it pro or is it con? And we will see it live on the screen, the results of the voting. So that's quite clear, right? Yeah, good. So without further ado, we will start with the question of should we prioritize patients according to clinical and preclinical obesity classifications? First out in favor of this is Juan Puyol from Spain. Welcome.
Thank you very much. Congratulations, Luis, for this excellent Congress. One of the best European I've ever been, and I've been to all of them. So my work is to define and to defend if we should prioritize patients by clinical against preclinical obesity, and I think obviously yes, because in countries where metabolic and bariatric surgery is mostly provided by public systems, such as most in the European region, the demand far surpasses capacity and leads to prolonged waiting lists. In Spain, for example, the mean delay is over 1 year, but in certain cases it can be over 5 years. And probably these situations is even worse, because you know that by the time the patients reach the surgical waiting list, they have already endured lengthy prior circuits, visiting dietitians, psychologists, endocrinologists, etc., etc., etc. And during this long waiting list, irreversible complications or death may occur. In a survey sent by the Spanish Society to nearly 200 surgeons, for example, half of them recall patients who suffered cardiovascular events during the waiting time, and even 20% report fatal cases. So problems can happen during the waiting time. But this risk of harm is not the same to all the patients on the list. Obviously, they are quite different patients, patients with a lot of multiple comorbidities, disabilities, impairments, and patients with low risk of having complications because they do not have metabolic abnormalities. The first one are the ones that have more complications. From the beginning of the century, we've mentioned the term metabolically normal or healthy obesity, which has become increasingly used to describe those individuals with obesity, but who do not have metabolic abnormalities. And their lifespan is quite similar to the average of the normal population, whereas patients with more obesity-related diseases, more complex patients and with disabilities, etc., they have more chances to have some complications where they are waiting for surgery. In a retrospective review, for example, they examined those patients who died while waiting, and those 22 patients, they have a mean of 7 comorbidities each. So they are complex patients, those who have more chances to suffer. In another analysis of a large cohort, it was found that obese patients with associated diseases impairments or disabilities had significant higher risk of developing complications if we compare with those patients who have adiposity, but apart from this, they are healthy people. So that's why in 2024, the Lancet Commission, led by Francesco Rubino, decided to divide the people with obesity in two great groups. Those with preclinical obesity, those were defined with people with excess adiposity, yes, but with no organ dysfunction. Those people can probably have a low health risk while waiting, whereas there's clinical obesity, those people with obesity as well, but with organ dysfunction or impairment to conduct daily activities. Those are the people who deserve a quick treatment. As has been demonstrated, for example, in many works, but this one is quite interesting. It's a big cohort of American people with obesity that found that clinical obesity, defined as the Lancet Commission, carries significantly higher cardiometabolic and mortality risk in comparison with those with preclinical obesity, where they have a very minimal impact on mortality. And not only is that they have more complications of, more chances of complications or even mortality, but the delay of surgery in those patients may reduce the surgical benefit. The SARS study, for example, reported substantially lower diabetes remission among those obese diabetic patients with longer known disease than in those with shorter known disease. So we therefore need a system that gives priority to these patients and ensures they are treated whenever possible, of course, before end organ damage occurs. So we have a strong medical and ethical reasons to prioritize these patients on the waiting list. But if these arguments are not enough, there are also strong economical advantages, because obviously these patients with obesity-related diseases and complications incur high healthcare costs, which obviously can be reduced when we take them to the OR. There are many papers that demonstrate these arguments, but let me, for example, mention the economical study that our ex-president, Ricardo Cohen, did, and they found that surgery was highly cost-saving in those obese patients with, for example, diabetes. And it's not only cost-saving, but also we gain productivity for the society. In another survey sent to obese people, unemployed people with disabilities and problems because of their obesity, they found that those who were operated have more chances to find a job within the first year after the operation, 24% versus 9% of those obese people that were not operated on. Well, one would say, what about patients with preclinical obesity? Because as new clinical obese patients with more complexity are seen, the healthy preclinical obese ones will never reach the top of the list and will never be operated. I agree. I partly agree. So I think that it's not only the complexity of obesity, but also a time in waiting list should be taken into account. But in any case, the natural history of obesity is poorly understood. So predicting who of the healthy people with obesity will progress is difficult. And in fact, as Lancet revision suggests to just monitoring and take care of these patients medically, focusing on preventing weight gain. Maybe those people with preclinical patients, obesity may benefit from waiting, as more effective options will probably emerge soon. So we have, I conclude because the time is running on, we have strong ethical, medical, and economical reasons to prioritize those patients who have a more severe obesity. And that's all. Thank you very much.
Okay, thank you very much. I'm sure there are lots of questions, but we'll take the other side now, the con, and then we'll have a short discussion and voting. So welcome, Victor Valenti, also from Spain.
Good morning. thank you very much for this kind invitation, Luis. It's a great honor to be here. So I have to say now, the answer is no. And I have to say, Joan, that your talk has been great, and I agree with many things, but I have to answer no. And I will try to explain briefly why not. So we have been working with NHI criteria for more than 35 years, and it's true that it's a simple criteria, but it has been a nice, simple entry point for many patients to undergo surgery. With the new Lancet proposal, I think that the problem here would be to demonstrate what is metabolic disease or organ dysfunction. Because as you know very well in this paper and in this figure, you have some of the different possibilities of metabolic diseases, but probably all of us will have other ones that could be included here. And if you are not included here in this list, you will be included in what they call preclinical obesity. And I think that these patients could be harmed, as I will explain later. I think that obesity, we think all of us that it's a very complex disease, and there are more than 200 or 300 health conditions related with obesity. So trying to reduce to a group, I think is a bit risky. From a theoretic point of view, for sure that this definition of obesity is much better than what we have before, for sure. But maybe what we can work a bit more is in the practical applications to the patients. And as I said before, no, when you divide into different boxes, the boxes related to the patients in the preclinical obesity are going to be difficult to manage. We have, and we know very well that a disease, every disease has like a path with different stages. And at some point you have signs and symptoms, and this is what we should call now clinical obesity. And these are the patients that we have to be more accurate with the treatment, with the bariatric surgery. If you read the paper, the nice paper for sure, you see that for preclinical obesity, what they recommend is lifestyle modification. And we know the results with lifestyle modification. Most of the patients are not going to do it well. Probably at the beginning they will lose some weight, but then they will regain weight. And we know that with bariatric surgery in this type of patients, we have very good results. This is the proposal, more or less, of the Lancet Commission, and this is the way I see, or the surgeons we see, what we have been doing for many years. We have different types of bariatric surgeries, and now we can say that we can tailor the surgery to the type of patient that we have. And we know that many patients, for example, a patient with no type 2 diabetes or only a beginning of type 2 diabetes, the result of surgery in this patient is going to be much better than in a patient with a progression of the disease. The remission rates are going to be much better. So I think it's still very important to do surgery in the early stages. In my mind also, it's like what we have been told in the faculties of medicine. We have to try to do a proactive medicine. To be proactive is to try to manage health before the illness occurs. I know that the Lancet Commission is just a definition, but probably takes into account or can tell us or can give us like we have to do now like a reactive approach to the medicine. Once we have the sickness, once we have demonstrated that we have an illness, is when we have to do the surgery. So the model is good, and I think they have some gaps in between the transition between body mass index and metabolic disease. And probably there are some patients that they can left behind the treatment. For example, I don't know, this is some examples of patients that we have done in the past, and maybe with the new definition, they will have some troubles to be included in the bariatric list. For example, this guy, Carlos, is a guy with no metabolic disease. The only problem that he has is that he's not able to carry heavy weights and move heavy weights in his job. He is not able, or he has been trying with GLP-1s, but he has side effects. So at the end, this patient probably in the past would be a good candidate for I don't know, a sleeve gastrectomy, depending on his comorbidities. And probably with the new classification, he will have troubles to be included in a bariatric list. So probably he will be excluded. Christine is a lady, 35 years old, obesity, depression. We know that both of them comes together many times. Probably is another lady that could be managed with a very nice bariatric surgery. If we try to put it now in the list, it's going to be impossible. She's not in the clinical obesity, so probably she will be outside possibility of surgery. Peter is another case. This is an interesting case because we have a case in the past. Peter is a gentleman with a primary biliary cholangitis, which is an indication for liver transplant. The problem with this guy is that in some places, if you want to put in the list of the liver transplant, you need to have a body mass index beyond 35. As with his disease not included in this list of clinical obesity, probably he will not be able to be operated. So he's like trapped, like this double stack, you know? Not bariatric surgery, no liver transplant. Well, could be another possible case. And Richard is another guy, but we can continue with other guys. With lupus erythematosus, we know very, very well that with bariatric surgery, the level of inflammation of these patients are going to decrease. So could be also a good candidate for bariatric surgery. Anyway, probably you have in mind many other patients. I don't know, most of you are surgeons and you have done these surgeries to this type of patients that in the preclinical obesity called now. And also, another consideration yesterday in the plenary session was very nice with Professor Rubino, with all the professors there. And they will explain this obesity classification, the Edmonton Obesity Staging System. It was published around 2009. And this classification includes functional status and what they call in the past comorbidities, now mental and functional problems. So the disease is classified in different stages. And if you compare the proposal of the Lancet and this one, in some way, more or less, preclinical and clinical obesity are included in these stages 1, 2, and 3. So, well, it's different, the point of view. No? In the left side, you have the old one. You include anthropometric components, the clinical components. You do a proper diagnosis, and then you personalize the treatment. Whereas with the new one, the definition is very nice, but when you classify, you divide, and probably dividing, what you are doing is a thought. I don't know if it is like this, but you are doing like a medicine centered in the disease, not in the patient. So in the left side is more personalized, in my opinion, than in the right side, but could be wrong. Anyway, the European Association of Study of Obesity yesterday, well, they explained their point of view. This is what they say. Probably, well, this is a statement. I mean, I'm not saying I agree with this, with all this, but this is a statement, and it's important when we are doing a definition that all the associations that we are working together, we have to be in touch. You know, if you are division or separation, it's going to be very difficult to advance. So they say increase stigma, create barriers, delay treatment, complicate clinical decision making, and potentially reduce insurance coverage. This is the final statement. What they say is the objective criterion should be the Edmonton Obesity Staging System instead of the new proposal. And this represents a potential setback in obesity management. Well, this is a strong statement, but this is what they have written. So in summary, and to conclude, the new classification could be useful. It's very useful. It's a good definition, but I think to put into practice this is more difficult. In some way, it fails to reflect the true complexity of what is obesity because of the many diseases connected. There is a difficult management of patients in preclinical obesity. We have to think on these GPs that are going to receive all this type of patients, and maybe they will have difficulties to send it to the hospitals. We know that bariatric surgery is an important tool to prevent and treat metabolic disorders. We have been doing for many years, and still there a very good option. And finally, well, still, this is just published last year. I think we need more time, we need more consensus, we need to explain things better, and once everything is integrated, probably we can include it as a new tool, important tool. Thank you very much.
Okay, thank you so much both for very persuasive arguments and very nice presentations. Now, it will be unfair to I think, ask one of you a question and maybe not time for the other one. So without further ado, I think we should vote. Are you convinced? Should we prioritize patients according to clinical and preclinical obesity? Or should we not? So you go into the app, you choose this session, you choose interactive features, and you vote. And we will see the results. Who will win? Oh, it's becoming more and more interesting now. Yes. Yes. Okay, I believe it has stabilized now. No? Okay, I think we have the result. And the winner is we should prioritize patients according to clinical and preclinical obesity.
We shouldn't.
We should. Right, Con.
We should.
No, shouldn't. Sorry. Oh, yeah, Con. Wow.
Well done, man.
Yes, we shouldn't. Thank you both.
Okay, let's talk about the second topic. The speakers are Violeta Moisés from Spain as Pro and Carmen Maillo from Portugal as Con, and it's about if we should use the high protein, low calorie diet in preparation of patients.
Thank you very much, Fatima, for the invitation, and thank you also to the scientific committee. So, well, I think that yes, we have to prepare. We have to always optimize our patients, our collaborators, to get the best of the whole process. So I don't have any conflict of interest to disclose related with this talk, except that we are not systematically, until now, preparing our patients with very low calorie diet or very low calorie diet with high protein intake before the surgery. But we do know, based in all our cohort analyses that we were conducting from a long time ago, that there is a high prevalence of nutritional deficit that may compromise the surgical recovery. So the most prevalent vitamin and minerals deficiencies, you already know them, but there are vitamin D, iron, folate, vitamin B12, and also protein malnutrition. So optimizing the nutritional status will go, of course, in favor of the impact of the surgery. So when we plan the optimization, we want to take this as an ERAS protocol that in this case will require a multimodal preparation that is going to be built on these three key biological pillars. So we will focus on the anatomical calibration based on the calorie restrictions. When we want to focus on reduce the steatosis and liver volume, this has been possible thanks to the very low calorie diet or low calorie diet with a great adherence and high protein intake. The second pillar will be the tissue resilience when protein and also macronutrients, in this case protein and immunomodulation takes place and protects this fast-free mass loss and also modulate inflammations. Here, higher protein intakes like 1.2 or 1.5 grams by kilograms a day, and also polyunsaturated fats plays a key role. The third pillar would be the metabolic calibration in this case with macronutrient repletion, and we want to correct these hidden deficiencies, always individualizing and based on the lab that we were conducting. So we should see these preparations, this process, as a 14 days physiological countdown, because everything is happening in this very short period of time. So we start 14 days before the procedures, where with a very low calorie diet or low calorie diet, because the difference is 800 up or 800 below or 800 calories a day, and starting back from them to the day 7 or day -7, -3 until the day of the surgery. Well, we find that at day -7, we already have the depletion of the hepatic glycogen. We also we have the maximum expulsion of intrahepatic water. So 40% of patients show to reach their greatest reductions here, 7 days. So at days -3, we get the preoperative glycemic remission. So we have a decrease in insulin resistance and a decrease in hemoglobin A1C. So at day 0, 90% of patients already have achieved the maximum hepatic volume loss. So it's good to know that it's not necessary extend this very restrictive diet more than that period, because there are not going to be like more benefits for doing so, and it can reduce patients' not only motivation but experience in general. But it's important to consider the protein shield that we need to build. For that, we need to include 1.2 and 1.5 kilograms of from ideal body weight a day of protein, which I mentioned before. That's why we need that high amount of protein in these dietary plans. And this has been shown to avoid a negative nitrogen balance. With this plan, 40%, 42% of reductions in the anastomotic leaks have been observed. Also, a decrease in 38% of surgical site infections and a reduction of 28% of global complication. And all this was based in the 2021 update of the ERAS protocol, between others. So another important point is to decrease the inflammation. This graphic from a notebook shows perfectly how the biomarkers of the inflammatory parameters are reduced, and also some favorable clinical and financial impact that contributes to the benefits of this optimization before the metabolic and bariatric surgery. And so we are in front of the need to redefine the surgical preparation, because of course we want to optimize with whatever we can. Even correcting deficiencies are already an optimization, but talking with our collaborators about the importance to adhere to the program and to get engaged in our visits long term is also an optimization of the program. But in this case, we want to focus on this biology that dictates the mechanistic aspects. We also want to consider that it's about 14 days that low-calorie diets are the gold standard to do this, and also that nutrition is considered in this case as a perioperative medicine. So I like these slides because it's showing how this multidisciplinary orbit goes around the patients. So in this case, we have like the clinical dietitians playing a key role in trying to reduce the barriers for our people to engage in this plan, in this dietetic plan, but working closely and in synergy with the surgeon and also with the anesthesiologist. So it has been shown that there is a high adherence even in the total diet or partial meal plan, and that's why the multidisciplinary person-centered care plays here an important role. So I would say that this is an opportunity to get to know well our patients, to try to transfer other aims, other outcomes, health-related outcomes, more than weight or beyond weight loss during the whole process. And we do like to share this commitment to comprehensive care, as I was saying, beyond the simple surgical success. So we want to offer this in a structured and personalized protocol, and as I was saying, it would be an essential pillar for the long-term success. And when are they indicated? Well, specifically in these special situations with BMI over 50, when there's a significant hepatic steatosis, a need for rapid metabolic optimization, or when we have a very limited surgical time frame. And this, I think, is my last consideration. Whatever we do, we need to think about increase the value that is based on the healthcare. So this preoperative nutrition acts as a surgical conditioning, but it's not just a metabolic preparation. So it's a value-based intervention that plans to improve the outcomes that matters to patients. And when it is true that current evidence is dominated by of clinical endpoints, I would highlight that there is a gap in the integration of the PROMs and PREMs in the preoperative nutritional research. So we should also include that in future research. So thank you very much. I see you later, and I invite you here.
Okay, thank you, Violeta, for your excellent presentation. Carmen, it's your turn.
Thank you very much for the invitation. It's really hard to defend against Violeta because she knows very well anything about nutrition in bariatric surgery. But what we are discussing here is the use of a very low-calorie diet with supplements versus a low-calorie diet. Of course, that our goal in the preoperative period is to prepare the patient for surgery, to reduce the liver volume, and these diets with supplements have really, really good results in this, but they have a cost. They have a catabolic state that can affect the postoperative functional capacity, the recovery, and they have a renal stress, and they have a flavor fatigue that can affect the adherence of the patient to this diet. So we cannot forget the cost of these diets. And when we study the effect of the two diets, we are comparing this with very low-calorie diet with supplements versus the whole food low-calorie diets, we see that the reduction in the liver volume is equal. We don't have a lot of differences so the importance in the preparation of the surgery, that it's our main goal, is equally got with both diets. So another thing that we have to consider is that we have to protect the lean body mass, and with these catabolic diets, there is a risk for losing this lean body mass. So if we can do a low calorie diet but with whole food, we can protect this free fat mass. And as we see in some studies, the Mediterranean and rich whole food diets preserve this fat-free mass, but it's very, very important in these patients that we are going to operate on bariatric surgery. We have talked about the renal health and glomerular preservation, and when we have an overload of protein, we put in risk this renal function. So that's something that we should protect as well. And of course, we have to consider an important hydration of these patients, but when we have a patient with a renal insufficiency, we should protect and we should avoid this diet with high protein supplements. But we have to consider other things, that it's the dietary variety. We have a problem with adherence in these patients when we are doing supplements. If you do whole food, you will have more variety. The patient can chew. It's not only liquid. It's important for the patient to feel the satiety, to really eat. And we will improve the adherence of the diets. It's a problem also of cost efficiency. The supplements are more expensive than the diet. And in patients that will do a surgery with a high cost, most importantly in the private practice, if you do these supplements, it will have a higher cost, and it can compromise the adherence for the diets. And the most important thing is that they do a good diet to prepare their body for the surgery. And another important thing is that when you are doing a normal diet, you are preparing the patient for a long-term behavior, eating behavior. So we have to consider this low-calorie diet with whole food have advantages and won't have those disadvantages of adherence and of cost. And we can do these diets with this basis, with carbohydrate control, and of course with the increase of proteins, because proteins are important for the recuperation, the recovery of the surgery, with a high hydration and really importantly, a control for macronutrition. And we have here a study where my colleague of panel is an author, and they analyze how the Mediterranean diet before bariatric surgery can be enough and good for these results, with enough total weight loss previous surgery, preoperatively, with a good reduction in visceral fat, and with a really good reduction in the left liver loss. So it's not necessary to do this supplementation with very, very low calorie diets, because with those diets we can achieve our goal preoperatively. This is the diet we do in my hospital. It's always an individualized approach with a low carbohydrate intake to reduce glycogen stores and liver volume, with a low fat intake to decrease the intra-abdominal fat and the liver volume, and increase protein intake to preserve lean body mass during caloric restriction, small structured meals, clear fluids and hydration, avoiding always alcohol and sugar drinks, and with a protein supplementation when it's needed. It's not routine preoperatively. It is in the postoperative period, but not preoperatively. And when it's needed, we do this supplementation. And this is the liver we find when we operate. It's a really healthy liver with this preoperative diet that we do. So the recommendation after this, the clinical guidelines should shift preoperative preparation away from synthetic, very low-calorie diets to 2 to 4 week whole food low-calorie diets. And this pathway guarantees the exact same surgical optimization while holistically protecting the patient's psychological and physiological well-being. Thank you very much.
Okay, thank you, Carmen, for your excellent presentation also. Okay, let's start the votation. You have the app? The question is, I remember, should we use a high-protein, low-calorie diet before surgery? Okay. This is the other one.
I'm winning.
No, it's not right.
It's not.
No, this is the previous, yes.
The previous, I'm sorry.
Ah, it's the previous. Oh. Oh. No.
Both
Let's
of
wait.
Are you voting? Yes? Okay, let's see the results.
I would like to know the number of voting. It's important to know.
Aquí, ¿dónde? Ah, aquí. ¿Se nos ve? Sí, aquí con la...
Everything is... Okay. Oh.
Pretty tight.
Whoa.
Amazing.
Please, that likes me, okay?
Is the final?
Congratulations.
Very good.
Nice.
Final result?
You deserve it.
No.
Yes?
It's 50-50.
It's
We count
voting, okay.
10, 9, 8, 7, 6, 5,
9.
4, 3, 2, 1, 0. It's okay?
Okay, both are the winners.
Thank you, Carmen and Violeta.
Okay, it's amazing. You are both, you're winners. Okay.
You're great.
Close to 10 years ago, I was very lucky in my hospital because somebody came to the surgical theater to offer to make opioid-free anesthesia. We are not going to make conventional anymore. So please, it's a pleasure to introduce Dr. Alfredo Malo, our anesthesiologist.
Good morning, everyone. Thank you for attending to this lecture, and thank you to the organization, particularly to Dr. Ocaña for inviting me. It's always a pleasure for me to speak about OFA, but today is not only a pleasure, but also an honor. I will quickly say that I have nothing to declare. I keep saying thank you to my colleagues in the hospital who are part of the opioid-free anesthesia research working group, and I wouldn't be here without them. And then, well, to get in material, I would like to speak a little bit about history, because sometimes to know where you are and where you want to go, you need to know where you came from. Well, modern anesthesia started at the end of 19th century, and it was based in inhaled anesthesia. Those days, you needed to use a really high dose of inhaled agents, which caused strong hemodynamic instability. It was the era where patients were more concerned about anesthesia itself than probably about the surgery. A second step was given in the 50s of last century with the development of neuromuscular blocking agents. There, we could diminish the dose of anesthetic drugs, so we had less hemodynamic instability, and the neuromuscular blockers gave also better conditions to the surgeons to perform the surgery. So they were great drugs. And in the 60s, we had a third step on that direction, because fentanyl was developed, and it was a great drug too, because it helped to diminish the inhaled anesthesia dose, but also helped with control pain after the surgery. So those were the three pillars where at the end of 20th century, normal anesthesia was based on. But by those days, the hemodynamic stability wasn't a big concern for anesthesia anymore, but we have these five issues that normally are related to anesthetic drug. Respiratory depression, which is very scary, but is pretty uncommon. Postoperatory nausea and vomiting, which is pretty common, particularly in bariatric surgery. Paralytic ileus, urinary retention, and emergence agitation. If you think of a family of drugs that is related with the 5 items, there is only one that will come to your mind, and those are opioids. And it's not a second side effect of the anesthetic drug, but we are also very concerned about pain. Well, thinking on this, we gave from the end of 20th century 2 more steps, because we started with multimodal anesthesia or opioid-sparing anesthesia, using other drugs with small quantities so we could lower even more the dose of opioids to reduce their side effects. And at the beginning of this century, some practitioners thought about what about if we could totally get rid of opioids and about their side effects. Well, it's been a few years since we started, so there's plenty of evidence about this nowadays. There are hundreds of studies that compare opioid anesthesia and opioid-free anesthesia and dozens of clinical trials. When you have this quantity of studies, the best way to approach them is with meta-analysis, and these are the main meta-analyses that have been published up to last week. As you can see, all of them find less postoperative nausea and vomiting. Actually, the reduction is over 50%, depending on the studies, but always over 50% of less nausea and postoperative vomiting. And the last studies also find an improvement in pain control for the patients. And 3 of them, one of them, our one, in 2023, that's from our research group, found more bradycardia with the OFA group. Well, but where does this bradycardia came from? The paradigmatic study is this one. This is the POFA trial. This is the main study against OFA because it was quite a terrifying one. They had to stop it because they find 5 cases of severe bradycardia, 3 of them ended in asystolia. But when we have a look at the study, the problem with it is that the dose that they wanted to administrate with of dexmedetomidine started at 0.4 micrograms per kilogram per hour. This is already a very high dose because in my place, the top we get is 0.3. That's the maximum. We start at 0.1 and get up to 0.3. But the rate they wanted to get was from 0.4 to 1.4 micrograms per kilogram per hour. If you pass the dose of 1.4 micrograms per kilogram per hour, it's well established since the beginning of the discovery of the drug that you will have cases of bradycardia. And the problem, furthermore, the problem they had is that when they actually saw what they did, they didn't get up to 1.4 because the median of the patients had a dose of 1.2 with a standard deviation of 2 micrograms per kilogram per hour, which meant that over 20% of the patients were overdosed, extremely overdosed with dexmedetomidine, so it's not strange that they had these cases of bradycardia. This is a very big study with over 300 patients, and when you get it in the meta-analysis, it has a strong weight that makes that you find more cases of bradycardia. Another complaint about OFA is that there is no standardization. For me, this is weird because it's something that you won't ask to the opiate anesthesia. You don't ask the opiate practitioner to have a real standard way of doing anesthesia, but you can do things on this. This is the protocol that we have in my hospital since 2018. We have already renewed it twice, improving it. Nowadays, at my place, it's not even the anesthesiologists who make the mixture of the 4 drugs that we use in the opiate-free anesthesia, but it's prepared in the pharmacy in sterile condition, which make it more comfortable for us and more safe for the patients to receive the drug. So you can standardize it, and that will diminish the side effects you will have with them. So in conclusion, all secondary effects of anesthesia are related to opioids. That's 100% sure. Opiate-free anesthesia is safe. There is a retrospective study from Dr. Moulier with over 3,000 patients, over 8,000 patients that show that opiate-free anesthesia has less side effects than opiate-based anesthesia. And we have a drastic reduction in post-operative nausea and vomiting, which is pretty convenient for bariatric surgery, better pain control, and obviously you go with dexmedetomidine dose over the limit, you will have problems of bradycardia. So thank you for your attention. You have here all the reference if you want to check them with the QR, so I haven't lied that much, and I'll leave you with Amador. Thank you.
Nice talk. Thank you, Alfredo. And thank you, Dr. Amador Garcia, our current president of Funseco, to accept talk against OFA.
Okay. I don't know if to say thank you because it's going to be tough to fight against Dr. Malo. So thank you anyway for the invitation. I have no disclosures for this presentation. The only disclosure I have is I am a surgeon, and I had to study a lot in order to prepare this presentation. When I began the preparation of this talk, of this debate, I tried to put on the shoes of Dr. Malo, and when I say, why should we use OFA? Okay, the potential side effects of opioids are especially severe in patients with obesity that we're treating, and all of them can be life-dangerous, life-threatening for our patients. So it's important to avoid or to reduce the use. There were several studies that recommend, and Dr. Malo presented a lot more, but also Dr. Malo has made a great presentation, so we should do for him. But why I should say no? And I'm going to go my argumentation through these different points. First of all, one of the main reasons for using OFA is because it's recommended by the multimodality recovery guidelines. If we go for the multimodality recovery guidelines for bariatric surgery, the last one were updated in 2021, probably too long ago. They only say that multimodal anesthesia should be used with a strong recommendation, but it didn't say anything about opioid-free anesthesia. It only said that multimodal anesthesia should reduce the usage of opioids, but with a weak rate of recommendation at that point. When I listened first about the opioid-free anesthesia, I went to my anesthetist at that time it was in Belviche, in Barcelona. They had a great experience in bariatric surgery. They are extraordinary anesthesiologists. And why don't we use this? And they told me, okay, you have to prepare so many drugs at the same time. It is one injection, later another one, later another one. And here you can see up to 7 different injections of different preparations. Okay, here in Malaga, you have solved it very well with a single preparation from the pharmacy, but I don't worry about that. I am worried about the potential side effects of all these drugs and the combination of all these drugs. And some of them can be dangerous, can be life-threatening for our patients. We have hypertension, we have bradycardia, we have some problems with the control of the pain. So some of them could be dangerous for our patients. We have some heterogeneous protocols. It could be a pro or it could be a con, depending on the cases. Dr. Malo presented that one of the trials had to be interrupted because the dosage of one of the drugs used was not adequate for these patients. But you do not agree yet about which is the adequate protocol for using this opioid-free anesthesia. And in this important step that we have to go through, it's important to take it clear for having enough evidence in order to support it. The benefits are not clearly demonstrated yet. We are looking for all these benefits. Oh yes, there are less nausea and vomiting, there are less postoperative opioids use, it is a good pain control, it's safe, but there is no improvement in the level state. Ambulatory surgery is going to be discussed in the next topic. It's not clearly stated in the field of bariatric surgery, and there are several doubts about their implementation, and it's not going to be implemented for the whole patients. It's going to be implemented for a specific amount of patients, a specific characteristic of patients. And actually, patients in bariatric surgery stay in the hospital for 24, 36, 48 hours. It's really, really rare the center that is keeping their patients more than 2 days in the hospitalization. And it has not been reduced by the use of opioid-free anesthesia. It has been reduced by other measures that include also the opioid-sparing anesthesia. And the most important thing for me is that the reduced respiratory depression. Patients who have a respiratory depression after the surgery when they are being extubated is very, very dangerous, especially in some conditions where everybody has gone out from the theater, everybody is preparing the next patient, is doing the paperwork, and the anesthesiologist can be alone with the help of other professionals, and this side effect it has not been clearly demonstrated. And I have to say that I found several papers that the use of opioids in the postoperative time, even using an adequate protocol of opioid-free anesthesia, has not been reduced at all. They have been reduced, but it has not been eliminated at all. So it should be something to be discussed in the future. I have taken to the whole two meta-analyses and comparing this is from 2022, comparing both protocols, there are benefits, clear benefits in the nausea and vomiting, in the control of the pain. But if we go for this paper presented last year, the real benefits are achieved by the opioid-free and the opioid-sparing anesthesia. Also, we are going to see less bradycardia in the opioid-sparing anesthesia. And it should be important for us also because tachycardia in the postoperative time is a very good marker of a potential complication in our patients. So we don't go to look for some kind of bradycardia in our patient that is going to mask a potential complication of the surgery. We are in 2026. The patient's perspective is much more important. And I found this interesting paper where different patients on a single center that opioid-free and opioid-sparing anesthesia were used, and they explained their experience in these different fields. And I found very interesting this explanation from one of the patients of the opioid-free anesthesia group that found that during the induction of the anesthesia, he was not completely asleep. He had some strange feelings. He had some strange sensations that make the surgery and the postoperative at some kind uncomfortable. So this patient perspective is also important, and we should take it into account too. And finally, it has not been widely used. If it's so good at all, why are not using it so widely? One out of the 4 main centers in Spain that are performing more than 200 bariatric procedures per year are not using opioid-free anesthesia. Just one of them is using it. In the Basque Country where I live, the main tertiary centers that we perform bariatric surgery, none of them use opioid-free anesthesia, and we have very good anesthesiologists, as you all know. And the main reasons are this one you have here enumerated. So, at the end, should we use opioid-free anesthesia? I have to say no, but probably not to be so weird, so hard, I will say yet. Thank you so much.
Okay, thank you, Amador. The positions are so clear. The arguments of both are absolutely perfect. So please voting. Go into the app and select the session.
Está apretado, no lo hemos hecho tan mal. Esto parece un debate de la CUP.
Tenemos elecciones andaluzas dentro de 2 semanas, muy apropiado.
Stop. Stop now.
Uy.
Yeah. Okay. Well,
I think we can assume a draw.
yes. This
Okay.
is a surprising.
Thank you.
result.
Thank you very much.
Okay. Okay, let's go with the last topic about if we should discharge the patient on the same day. It's an important and also a very current topic, I think. We have two speakers, Simon Nieuwhuis from Netherlands with a pro, and John Preto from Portugal, ASCON. Thank you very much.
Well, thank you. Another opportunity to at least advocate in favor of the same-day discharge. The disclosures are here and actually not really relevant to this topic. And of course, you could state, why should we think about same-day discharge? I mean, what is really the patient preference? Is it safe? You have to reorganize, you have to use monitoring, and especially how about insurance coverage? And I mean, why is it necessary? Please leave this complex surgery as safe as possible, you could say. And actually, has been studied as well, that in a survey amongst surgeons in the American district, many have a lot of concerns to proceed towards same-day discharge. Nevertheless, it was an idea to at least have this service available, but to be honest, we were looking for the opportunities. How can we at least get the assumption of whether or not it is safe? And we found this solution in an aid, which is a wearable. I'm talking about the HealthDot, which is an accelerometer, which means if you put it on your chest on the left side, it measures the frequency of your heart as well as your expansions of your lungs. So you're able to monitor the patients about the two most important vital parameters, and it is automatically transferred in our EHR system, so you can see for every 4 hours the mean. First of all, we had to see whether or not it is working, especially in patients living with obesity, and the summary of this graph is, yes, you can rely on it. Next thing was, okay, you get some information every second, and that's way too much. So you don't want to have, looking in a grid iron analysis, as you see here, you don't want to have measurement with a wearable, and in reality, there is a tachycardia, or the other way around. So if you're not taking every data point, but only the mean, the average of every 5 minutes, as you can see here, you can rely on it. Furthermore, as we are used to have an early warning system score relying on multiple factors, now we have to rely on only 2. And actually, our normal early warning score system, or most use even the modified EWS, WS, still is not as good as it is with this only on 2 parameters. So it's working. And so I suggested in the group we can start with same-day discharge. And of course, all my colleagues were very enthusiastic. And everybody said, well, yes, let's go with it. We needed some more additional meetings before we could start with an investigation plan. And as you can see here, it was called the Post-Bariatric Early Discharge Controlled by HELDOT, and everybody remembered PEACH. So we started with the PEACH trial just based on the patient preference, whether or not the patient was willing to go home the same day. And within this trial, as you can see here, the HELDOT was applied for the patient, and of course we had some additional checks. For example, you have to drink enough, hemoglobin should not be dropped too much, and the pain should be less than score of 3, and in all those cases you can go home. And the summary of that study is, yes, it is feasible, and with the same satisfaction, and of course you have a reduction in your hospital stay. So from then on, we started to provide this service as a standard, which means as long as you don't have any barriers in language or problems in your household, and especially if it was not your preference, we say if the procedure is performed and has ended before 2 in the afternoon, you have a co-responsible someone at home, lower EBS, a lower pain score, and HELDOT should be working, and we use passive surveillance, which means the next morning when one of my colleagues does the phone check with the patient, we have the information with us. And in case of a patient contacts the hospital, we have something to rely on as well. So after 3 years, you can see here that more or less we are now towards the 50% of our patients who go home the same day. And you look at the total patients who did go home the same day. Yes, of course, we have had our complications as well, and I think they are more or less in the range what can be expected. So after 3 years using this kind of protocol, you see that's more usual care. You start worrying about what is the real profit of the monitoring. There has been a systematic review where you can see the differences with or without monitoring. And to be honest, we feel already the same way. Maybe this wearable is not useful anymore. However, it was a real catalyst to get this protocol working in our hospital. So, as requested, with a lot of our own evidence, so do we need more? I mean, I was lucky enough that we even have already an if-so statement. So I could sum up a lot of literature who already state you can do it safely. In this statement, here you see the results of the 4 randomized controlled trials. To be honest, when you look at it, because I know it's our own trial, it's mentioned double, so a little remark on this one. But also, if you look at the non-randomized controlled trials, in the end, it seems to be safe. There is one point to be made about mortality. There is one 12-year-old study who has reduced the results for this one, but in the end, yes, it was recommended. In this position statement, there is a list which should be taken into account, but we don't have a formal protocol. You could state it is safe. Furthermore, there is a preference of the patients for using it. It's not only with metabolic surgery, you can see here other kinds of surgery wherein it's a patient preference to go home the same day for a large group. Is it cost effective? Well, if you look at several studies that looked at it, twice it really was found evident for lower hospital cost. In one case, it was not really significantly. And of course, it is financially viable if it's closely linked to the length of stay. And that is a problem in some countries where the reimbursement is correlated with the length of stay. So in the end, I would say that same-day discharge is safe. There is a large group of patients who prefer it. You can reduce your cost, so I think it's wise to do so. Thank you.
Thank you. Thank you, Simon. Thank you for being so clear with your presentation. John Preto.
Good morning, and first of all, I'd like to thank the IFSO and the organizing committee and the person of Luis Alcaña for this dear invitation, the opportunity to participate in this table. So I was given the task to be against the same-day discharge of our bariatric patients. But I think that we will probably be more discussing if we can generalize this or if we can't, in some of the issues that Simon has already talked about. These are my disclosures. And so it's a fact that same-day discharge is often presented as a natural evolution of enhanced recovery after surgery. We know that. The issue is the evidence tells a different story. When we look at this study by Barani in 2024, this is a retrospective study, 6-year time span on the Metabolic Bariatric Surgery Accreditation Quality Improvement Program, but it has an interesting difference based on other retrospective studies because Barani and his team did a propensity score matching. The method allows it to mimic RCTs and to reduce bias and confounding factors. We're comparing here in this study apples to apples. It's true that in this study, they noticed in 6 years that there was an increase in the rate of same-day discharge of bariatric patients. But they also reported that there was a higher 30-day mortality, 2.11 odds ratio, compared to the patients that were admitted in hospital. Patients that were discharged on the same day had a higher cardiac arrest, higher dehydration regarding treatment. And even though overall major complications were lower in the STD cohort, it is true that there is a bias and a selection bias in the majority of the centers, as we saw in Simon, when they allocate patients to STD. And also, in this study, Roux-en-Y gastric bypass had an increase of 72% of postoperative complications compared to sleeve in the cohort of same-day discharge. And which were the patients in this study that were high risk for the same-day discharge? Patients with depression, 6.5-fold increase of readmission. The Hispanic patients and the Black patients, 9 to 56% increase in readmission. Higher BMIs, higher age, multiple comorbidities. Roux-en-Y gastric bypass patients, and patients with functional limitations. When we look at the study of Ortega, which was a systemic review and a meta-analysis, he also demonstrated that same-day discharge was associated with significantly higher risk of 30-day mortality, 7.25 odds ratio, and also a rise in overall morbidity compared to hospital admission. And Simon Group's paper, a preference-based randomized trial, as he explained, which there are not many RCTs in this area, concluded that it's not superior to admit the patient. And just as he mentioned, the outpatient surgery protocol was neither inferior nor superior. It was practically the same and comparable. And what about the readmission problem? We know in bariatric and metabolic surgery, readmissions can rise at 30 days up to 10.8%, and up to 90 days it can rise to 23% in various studies that are published. The problem with this is that we know that bariatric patients that are readmitted have a 10 to 15 higher mortality and double the length of stay. The most common cause, 1/3 of the patients, nausea, vomiting, dehydration, as we saw in Barani's study. And also, we can't dismiss the physiological burden that these patients have. Now, I'm not saying in none of these studies that patients that are subjected to same-day discharge have higher readmissions than patients that are admitted. That's not what the evidence says. What we say is that, or what I'm saying is that patients probably, if we generalize STD, probably it's expected that we will have more readmissions, and this will come at a cost for our patients. What about patient satisfaction, as Simon referred to? 2 papers published regarding patients' preference for same-day discharge or hospital admission. And none of the studies demonstrate that the patients prefer to go home on the same day. In both studies, they report equal split between admission and same-day discharge. And we look at Simon's group's papers of the preference randomized controlled trial, and the patients preferred one or the other. Each arm has practically the same patients, which supports these studies also. So we can't practically say that there is a generalized patient satisfaction regarding this. And what about economics? We know that readmissions after bariatric surgery is estimated at $234 million cost nationally in the United States. A single readmission costs much more than an overnight stay. And when we factor in emergency visits, readmission costs, medical legal risks, and patient suffering, we see that economically we can't also say that there is a clear benefit from a same-day discharge of our bariatric patients. In terms of our personal experience of our group that was also asked for this presentation, I come from a very high-volume center, the major university hospital in the north of Portugal. And last year in SECO, we presented these results based on our primary cases of our Roux-en-Y gastric bypass and sleeve, and also our revisional. During the past 21 years that we've been performing anastomotic procedures for bariatric patients, we, in this cohort, approximately 3,000 patients, and in the past 3 years, we have been performing close to 900 patients per year. And as we can see, the results are very comparable to benchmark results. We have come over these 21 years from 7 days admission, 5 days admission, 3-day admissions. In the past 7 to 8 years, we have been practicing 1 to 2 days. There are patients that are discharged before 24 hours. There are patients discharged at 36 hours. No patient usually stays more than 48 hours. And our results in primary cases and also in our revisional cases are comparable to the benchmark standards for bariatric and metabolic surgery. So we feel very comfortable with this practice, and we don't feel the urge to implement these same-day discharge protocols. In summary, we see that by the studies I showed that evidence does show higher mortality, cardiac arrest, and dehydration rates for same-day discharge. Studies supporting same-day discharge come, in the majority of the studies that we review, highly selected patients, high-volume centers, intensive follow-up systems. Just as we saw with Simon's group, they have remote monitoring. Majority of the centers that publish STD do not have these systems implemented. And so usually there is a bias in the studies that we see on same-day discharge. The majority of the bariatric patients have characteristics that are inappropriate to same-day discharge. There are studies published recently that show that 1/3 of the patients are candidates for same-day discharge. 2/3 of our patients do not qualify for those criteria that we saw in Simon's presentation in the majority of the papers that are published. Another point that I like to reinforce is that there is a need for clarification and standardization for same-day discharge. When you review the literature and the studies, it's very difficult to compare the studies. Some groups will say that same-day discharge is on the same day. Others will say that it is before 24 hours in an outpatient ambulatory protocol. There are groups that use telemonitoring and remote monitoring for their patients. Other patients have different criteria. So there is a need, in fact, that the patients that do qualify for same-day discharge, we need some standardization, clarification, so that we can compare between different centers. Leading societies do support early discharge. It's true. Simon referred this. But when you look at the IFSO statement, as was mentioned, on the 6th point, the recommendation of the task force is it should be treated within the framework of clinical studies and/or institutional protocols. This is a fact that we're not saying that it can't be done, but it still has to be done. We cannot generalize this on our patients. So I believe that the discussion should be which are the subgroup of patients that can benefit from same-day discharge and which are the patients that cannot and should not have same-day discharge. And finally, especially for the young surgeons that are starting as bariatric and metabolic surgeons, I think it's important to reinforce that in bariatric and metabolic surgery, success is not how fast the patient leaves, it's how safely they recover. Thank you very much.
Thank you, John, for your excellent explanation and for having a critical vision so necessary. Okay, let's start with the votation. Wow, the difference is clear at the moment. Okay, I think we can stop. Yeah? Stay. Okay. Thank you very much, both.
Thank you. Thank you. Okay, so during the presentations we didn't allow any questions, but many of the questions are, have been pros and cons, and there has been voting in both directions. So the floor is now open for discussion, and maybe we can invite all the speakers up front.
Sorry, the session is not yet finished. I'm sorry. We have 15 minutes. We are very lucky because we was thinking a session with 8 speakers. I never think about it's going to be so dynamic as it was finally. So we have all more 15 minutes. So we are going to use 13 minutes to the audience to ask questions, please. I think all the debates was so close, so the arguments so great. So please, if you want to ask any question.
I do have one question. What do you do when... sorry. My concern is discharge in the same day is the hydration of the patient. A patient operated of metabolic and bariatric surgery cannot drink enough the first, the second day. So what do you do to solve that problem, to keep the hydration of these patients when they are discharged in the same day?
There is already some additional hydration during and after the operation at the recovery room, and those only with sufficient between 300 to 500 milliliters at the ward are allowed to go.
Okay, so that's really a concern.
It's not a concern as it seems to be achievable by
Okay.
many, but it is taken into account before you can be discharged.
Okay.
Yes.
You have the microphone right there, please. Thank you.
Hi, I have a question regarding the opioid-free anesthesia. Do you feel it has any negative impact on the flow of the room? Meaning, does it take longer for the patient to emerge from opioid-free anesthesia compared to none?
No. Simple. No. If you have, you have to mix 4 drugs normally. There are several ways of performing opioid-free anesthesia, but you have to make the mixture of the 4 drugs, but you can always do it in advance. In my place, we already have it from the pharmacy, which is great, but even if not, you can always prepare it before you start the surgery season. If you start to prepare them once the patient is already there, of course it will, because you have to make a... No, the emergencies... Right, though. The emergencies is a curious thing because normally, and we have just finished a clinical trial on this, so I have now dates of my own place, and the emergence for the time to the extubated patient is shorter with the opioid-free anesthesia. And there are some trials that go in that direction. But if you want to have the patient fully recovered, it will take a little bit longer. What is the difference? The difference is that when you use opioids, then you need a lower, you wake up with a lower level of gas, of inhaled agent. When you don't use opiate, the patients, they recover the respiration, the capacity of coughing and everything, but they are not that aware. So what we do is we extubate them when they are not 100% conscious. You see? But it's quite safe because they don't have any respiratory depression, and they don't have and they can cough normally. Okay.
Okay.
Nick Hormus. A question to the first speakers. Yesterday I spoke with Francesco Rubino after the talk, and I said to him, it's almost a pity that you didn't have not only preclinical obesity, clinical obesity, but severe clinical obesity in your classification. And you touched on it when you talked about the Edmonton obesity score. I'm not saying that everyone that has surgery should be severe, but shouldn't we be targeting those people who need help first? Because in most other disciplines, surgery, when resources are limited, is directed to the people who need it the fastest, but we don't seem to be doing that at the moment. And that's where incretin medications have snuck in, and people have said, why should I send someone to surgery when I can get the same effect with medications? But they can't get the same effect with the people who are much more severe. So I just want to hear your views.
Well, following your suggestion, I would like to make a question to the audience this time, because I think that what we're discussing here is not operating or not operating, but prioritization. Prioritization means those who need more or those who are in more urgency should pass in front. And then I was quite shocked because you vote, no, I don't think so. So if a patient has a complex obesity that needs prompt operation, and the other one is BMI 35 with mild comorbidity or even without comorbidity, wouldn't you take first, if you have only one option, one OR, wouldn't you take first the more complex obese people? I'm quite shocked. So what's your philosophy then? First to come, first to be operated always? Even if you have one that is suffering or disabled to work because of their obesity? Thank you.
Well, basically, I agree with what has been said here. The thing is also, as surgeons, we know that sometimes we arrive very late to the patients. We know that sometimes we are operating a patient that has been in a waiting list for 5 years with heart attack, with sleep apnea, with whatever, and we are feeling the best option for this patient was 5, 6 years ago. But at the same time, I agree with what we are saying. Sometimes you have to prioritize. And it depends on the system, the place, the country where you work. You have to think on your possibilities. So I agree with both approaches, you know.
Yeah. Totally. So that's why prioritization is not that easy, and there's no consensus anywhere about how to prioritize patients. And I think it should be multifactorial. Also, time on waiting list, of course, but also can be age or benefit after the operation. Maybe a very severe people, should be operated in advance, but maybe the benefit that they take after the operation is not that much. So it's quite complex and that's why it doesn't exist a consensus about how to prioritize patients. Thank you.
Ricardo Cohen. There's a big confusion here, mainly in the second presentation on the Lancet Commission. The Lancet Commission is a definition of a disease as all diseases in medicine, everyone. We don't have to have another disease to say that obesity is a disease. The biggest example is Spain. GLP-1 receptor analogs are given to people with diabetes, not with obesity. So first, we do not draw a line between treatment and no treatment. We draw a line between a diagnosis of a disease by its own. Saying that obesity carries 200 or 2 million diseases doesn't matter, because we have one disease with one entity by its own. And to different levels in a population level, to prioritize patients is fundamental. This is done in all diseases, everyone. Why not in obesity? And we do not advocate, as I heard in the presentation, that preclinical obesity undergoes lifestyle interventions only. We do not draw lines in treatment. We say preclinical obesity is a risk state. It's not a disease by its own now. And high-risk patients need treatment, medical or surgical. So to avoid confusion and conflation, we are proposing a disease diagnosis as all diseases. Look at lupus. Lupus is a disease with 10 signs and symptoms, major and minor criteria. And they made the diagnosis of lupus. We don't need diabetes for lupus. And I ask you the opposite. Do we need obesity to make the diagnosis of diabetes? No. Why should we need diabetes to make the diagnosis of obesity? We have a disease by its own, and what we have is 18 signs and symptoms attributed to excess adiposity over the body. So obesity is not only metabolic, it's not metabolic diseases. Obesity is a disease by itself. Second, the staging system, the King's, the EOSS, the Edmonton, they are staging systems after a diagnosis. So I cannot stage something that has no diagnosis. And again, the staging is based on other diseases again. So we're not against staging. We're against the way of a confusion between what is a disease and what's not a disease. So preclinical obesity is excess adiposity without organ dysfunction at the present. Depending on the risk, she or he needs to be treated. GLP-1s, Contrave, surgery, whatever you want. And clinical obesity demands treatment now, not postpone treatment. This is the philosophy of the Lancet Commission. It's not a management framework, it's a diagnosis as all other diseases. So if you go to a cancer conference, cancer conferences are exactly the same. This is a disease, this is a protocol for treatment, and that's all. So again, an example for the surgeons, we have colonic polyps and colon cancer. It's the same spectrum of a disease. We don't prescribe chemotherapy for polyps, but we do for cancer, and it's the same spectrum. So it's the intensity of the disease, of the target of the treatment that matters. Preclinical is a risk state, not a disease yet, and clinical obesity is a disease that demands treatment now. So this is the framework of the Lancet Commission. It's not management, it's not a confusion on severity scores. We should stop saying that obesity carries 2 million diseases because this doesn't add up to our plate. On the contrary, we're still depending on other diseases. We know, of course, obesity is a harbinger of other diseases. We're not questioning this. And of course, the management is different than a diagnosis. But if you have a patient with preclinical obesity and diabetes, the Lancet Commission does not say do not treat. Treat, because we know that weight loss is good for diabetes, period. So it's as much more simple than we might think. Thank you.
Thank you, Ricardo, for your remarks. We have 4 minutes. I'm going to make a question for the preoperatory with supplements. Was so tight, the votation. So what do you think about the patient preference?
That's the only point. Okay, you go. You're the winner.
No, yeah, you are so close.
Okay, I think that the result of the votation is a reality of what's happening. I think that the very low calorie diet with supplements, it's a simple diet to prescribe for the patient to do with really, really good results. It has some risk, but we are talking about short period of time, and we are talking about high hydration. It has some problems with variety and flavor and adherence, and that's where the patient preference comes into the equation. It's expensive, so in my practice, it's private practice, it's hard to implement. But we are talking about short period of time if patients without any other disease or any other physiological considerations. So in general, we could do this diet because it's really, really good for our goal that it's to prepare the patient for the surgery. But the other consideration that we have included in the patient preference is really important. And another thing is that we have to prepare the patient for the future, and they are not going to be taking these supplements forever, and they will learn to eat. And in this previous phase, it's important they start to learn how to eat and what the diet they have to follow for the rest of their lives. So in all this equation, patient preference is a really important thing. It's a good diet when the patient doesn't know how to eat and will not prepare the meal that they need. So it's simple, just take these liquids, it's okay. But the result of the votation is the reality. We have this weapon in our hands, we can use it, but we really have to consider the risks and the patient that we have. So patient preference is one more thing to think about when we prescribe this diet.
Yeah, I agree. I mean, I would just say that certainly this needs a carefully management. I mean, and it's not going to be universal approach. So it's good. We have, as Carmen said, we have this option, and it's good to negotiate and to see what is convenient for the patient. And in case of it's convenient and they don't want, well, this is also another important reason to consider. So.
Thank you. Well, next Monday, if I have to sit down and to prepare my schedule for the next month, if I decide to do, as I understand, I learned this morning, so all of you vote, then I am going to prepare the first patient, and I have to take care about okay, it's important, the remarks of Dr. Ricardo Cohen, obviously, but the result of the voting is I don't take care about the preclinical or clinical classification to decide the patient is going to be the first next week in the surgical theater. And I can offer the patient if she or he want to be prepared with supplements or not, with maybe Mediterranean diet. This is very important because, you know, it's a reason also to make a randomized control trial in your hospital because especially between 40 and 49 BNI, I think there is no clear result about what's better, diet or supplements with protein. So I will call the patient, you are going to be operating in 2 weeks, and it's up to you. If you want, you can prepare with supplements 10 years previous, or maybe you can make a diet. I'm going to offer you, I'm going to send you by email the diet you can prepare for the surgery. Because it looks like it's your opinion, or the audience looks the same, these both preparations. Also, the preference of the patient is very important. Maybe we can ask them, okay, it's up to you, but the evidence is going to be perfect. I agree, if you are high of 50 BNI, I prefer to prepare the patient anyway. So let's talk about the anesthesia. Looks like for your voting, doesn't matter. If you use conventional or you use opioid-free anesthesia. Unfortunately, we're surgeons. We have nothing to say to our anesthesiologists what you have to do, and we are very lucky to be in your hands. So, okay, we are going to use both as more comfortable feel the team in every hospital. And finally, what are going to do the patient? Okay, I'm sorry, Simon. Okay, I know the arguments, both arguments, was absolutely very interesting because, you know, we're thinking about to do the best. When we start making starts as a protocol or fast-track surgery, we throw away all our master. We take the patient meal 6 hours later, the surgery, not 1 week later. We send the patient same day, next day, sorry, or in 2 days. For us was, you know, we feel pretty nervous. But to send a patient with BNI, maybe 57, the same day, okay, he's going with a marker, with monitorization, but you know, I don't feel pretty good, but I know this is the future. And the preference of the patient, you was talking about it, is so important. Maybe in selected cases, for example, if I have to choose a patient to go the same day to home, I prefer a bypass instead and sleep gastrectomy because he's going to have less vomiting. And desafortunately, you lose, and maybe in a few years you are going to be the winner. So I am preparation the patient, and I will send the patient next day or in 2 days home. I hope you take skills for your management in your bariatric team, and thank you everybody.